Hello and welcome to AIH Connected, our online patient conference. My name is Erin Anderson and I'm the Director of Programs and Advancement for the Autoimmune Hepatitis Association. I'm so pleased to introduce the speaker for our next talk, Dr. Therese Bittermann from the University of Pennsylvania. She is going to give a presentation that is perfect for newly diagnosed patients, but is also one that patients who have had the disease longer will also benefit from. Dr. Bittermann is an assistant professor of medicine in the Division of Gastroenterology and is also a senior scholar in the Center for Clinical Epidemiology and Biostatistics. She sees a number of patients with autoimmune hepatitis, and AIH is also a research interest of hers. Welcome, Dr. Bittermann.
Well, thank you so much for the opportunity to speak with you all today. And today I'm going to go through autoimmune hepatitis basics, sort of the 101 course to autoimmune hepatitis. My name is Therese Bittermann, and I'm a hepatologist or a liver specialist over at the University of Pennsylvania in Philadelphia, Pennsylvania. So I'm going to share my screen. All right, so first of all, I think one of the more important questions is, what is autoimmune hepatitis? So autoimmune hepatitis is an autoimmune disease of the liver. And the way I explain it to my own patients is, for some reason, your immune cells decide to target and injure your healthy liver cells. And so this causes liver inflammation, damage, and over time, some scar tissue to form in the liver. We think that autoimmune hepatitis, or AIH, results from a person's genetics. So there's something inherent to these patients that predisposes them to autoimmune hepatitis. And then there's possibly one or maybe more environmental triggers that, in combination with the genetics, lead to autoimmune hepatitis. We know that autoimmune hepatitis occurs both in women and men. However, it is far more common in women. It also impacts patients of all ages. It's been described in children as well as patients who are in their 80s and even 90s. However, the typical peaks that we see are younger folks in their teens and 20s, and then older or sort of middle-aged in their 40s and 60s. We also know that autoimmune hepatitis affects really patients of any racial or ethnic background. There may actually be some differences in terms of how patients progress with their autoimmune hepatitis, depending on some of these racial or ethnic factors. But it's been described really throughout the world and among all populations. Autoimmune hepatitis is a rare disease. So in the US, it only affects about 1 in 30,000 patients. Frequently, because it's so rare, there's no reported family history of autoimmune hepatitis. But what we do see is that patients tend to have an increased family history of other autoimmune diseases. And so that can include things like thyroid disease, inflammatory bowel disease, etc. In addition, about 20 to 40% of patients have another autoimmune condition when they're diagnosed. And so that can also include things like hypothyroidism or thyroid disorder, inflammatory bowel disease, celiac disease, among others. So let's take some time to talk about the diagnosis of autoimmune hepatitis. So the first sign is often a labbed abnormality, and that's the elevated liver enzymes. So liver enzymes are basically proteins that live in liver cells, and then in response to inflammation or injury, they get released into the bloodstream. And so that's how we detect them. And so there's two primary elevated liver enzymes that we monitor. One is alanine aminotransferase, or ALT. That is primarily in liver cells. And then another is aspartate aminotransferase, or AST for short. And that can be present both in liver cells and in other tissues in the body, such as muscle tissue. These liver enzymes can be elevated in a whole wide range. So What we would consider mild would be elevations that are less than 100, but they can go up to the thousands or even the tens of thousands in patients who have severe liver injury. In terms of symptoms, well, about a third of patients actually don't have any symptoms at all. And so what often happens is that these abnormalities on lab tests are just found incidentally when people are getting routine lab tests drawn by their primary care physician. On the other end of the spectrum, about 5% of patients actually develop liver failure and jaundice, which means sort of yellowing of your skin and your eyes. And then for the 60 to 70% of patients in between, there can be a whole host of different sort of non-specific symptoms, the most common being fatigue in about 85%. Other symptoms can be poor appetite, maybe some joint pains or irregular menstrual cycles in women. So who makes the diagnosis? Well, so as I mentioned, a lot of times what happens is that the initial lab work is actually done by your primary care physician. And depending on their level of comfort, they may actually also order some of the other early workup tests. But ultimately, patients are referred to either a gastroenterologist or a hepatologist. And so I'll take a quick minute to just describe the difference, because sometimes it may not be apparent. So a gastroenterologist sees all gastrointestinal and liver disorders. However, it's important to remember that some gastroenterologists may see very few liver disease patients in their practice. And so they may be far more comfortable with some of the more gastrointestinal disorders and less comfortable with some of the liver disorders. It's very variable. A hepatologist, on the other hand, or a liver specialist, has typically completed additional training to specialize in liver diseases, including in the care of patients with end-stage liver disease and liver transplantation. So when should you see a hepatologist or a liver specialist? Well, who you see initially may actually depend on where you go for care. I practice at the University of Pennsylvania, which is a big academic center in Philadelphia. If you were to first seek care there, because you have, liver abnormality, you would go to see a hepatologist right off the bat. But in the community, sometimes various community practices may not have a hepatologist on staff. And so you may actually see a gastroenterologist first. I would consider seeing a hepatologist if your case is not very straightforward. So maybe there's some uncertainty with the diagnosis. Maybe you already have another liver disease, or they've found another liver disease, or perhaps you can't be treated with the usual medications for some reason. I would also consider seeing a hepatologist if it's found that you have cirrhosis or signs of quite severe liver damage. And then also if you don't respond to sort of the typical initial treatment. What I tell a lot of my patients, in my own practice is, many of my patients, they can travel for 2-3 hours to come to Philadelphia. And so what can be really helpful is for them to have a local gastroenterologist that they see perhaps, intermittently, that they can access easily. And then I can help co-manage with that person. And then potentially the patient then has less trips down to Philadelphia to come see me. And so we can sort of work together to provide the best care. But I think at the end of the day, what's most important is that you feel that you have a good working relationship with your doctor, that you feel that that person is trustworthy and dependable, and that you're able to feel listened to and freely ask questions. Autoimmune hepatitis is a disorder that for many patients will affect them for several years. And so you will likely work with that person for a long time. So it's really important to have that good relationship with them. In terms of the initial laboratory tests, so we already talked a little bit about the liver panel. So the AST and ALT are usually elevated. The other two tests that you'll see on a liver panel are the alkaline phosphatase and the bilirubin. The alkaline phosphatase is usually normal or near normal, and then the bilirubin can be elevated, but really only when patients have severe liver injury. The bilirubin is actually what causes people to have jaundice, or sort of that yellowing of the skin in the eyes. So typically, if there's severe liver injury, you'll see the bilirubin be elevated, but outside of that circumstance, you usually do not. There are some other tests that help support the diagnosis of autoimmune hepatitis. These can include antibody levels, in particular, anti-nuclear antibody, or ANA. That's elevated in 80% of patients, and anti-smooth muscle, or ASMA, antibody, that's elevated in about 60% of patients. Sometimes your physician may also order some less common antibody levels, which I won't go into great detail here. And then the other thing that is typically ordered is the immunoglobulin level. And so what we typically see in autoimmune hepatitis is an elevated IgG. And IgG is basically a broad class of antibody that's in our body. While we're confirming the diagnosis of autoimmune hepatitis, we also want to rule out alternative diagnoses. And so typically patients are tested for viral hepatitis. So that's hepatitis A, B, and C. There are also some other less common viruses that sometimes we will test for. We want to know whether there's a contribution of alcohol-related liver injury and non-alcoholic fatty liver disease. So non-alcoholic fatty liver disease is liver disease that results from folks being a little bit overweight, having diabetes, cholesterol disorders, etc. We also want to know whether there's a presence of another autoimmune liver disease. So there are several other autoimmune liver diseases that exist. And then oftentimes on history, we'll be asking about recent drug exposures or medication exposures, because sometimes those can cause a liver injury that is very similar to autoimmune hepatitis. And so we want to understand whether there may be a contribution from drug-induced liver injury. There are also some disorders and diseases that we will check for to see if they're actually present at the time of diagnosis. And that includes celiac disease, which is more common in patients with autoimmune hepatitis, as well as thyroid disorder. So both of these should be tested for when you're suspecting autoimmune hepatitis. And then also vitamin D deficiency is recommended to be tested for. What about imaging? So imaging is not required for the diagnosis, but it's often obtained as one is pursuing a workup for autoimmune hepatitis. And typically, it's a routine ultrasound of the liver that's obtained, and that's really usually sufficient. That can provide a number of different points of information. One would be to assess for signs of cirrhosis. So cirrhosis of the liver basically means a late stage of scarring of the liver. And there's about 20 to 30% of patients diagnosed with autoimmune hepatitis have cirrhosis at the time of diagnosis. So certain signs that might clue you into that would be the spleen size, whether there's fluid or what we call ascites in the abdomen, and then also obviously the sort of appearance of the liver as well. We may also check for other things that could explain the liver test elevation. So perhaps, make sure that there's no sign of liver cancer or any liver masses that might explain the abnormalities in the liver tests. Look for gallbladder disease or gallstones, or even a bile duct blockage from a stone, for instance. So what about the liver biopsy? Why do you need one? Well, the reality is that the diagnosis really cannot be made without it. And there's a couple of reasons for that. Number one, those tests, the ANA and the ASMA, can be elevated in patients who do not have autoimmune hepatitis, even if they're healthy or if they have other liver diseases. In addition, about 1 in 5 patients with autoimmune hepatitis don't have any of the typical lab tests. And so you may need to pursue the liver biopsy in order to confirm the diagnosis in those patients as well. It might be your only finding, really. And then the other thing that I tell my patients is that the treatment involves long-term immunosuppression. And so that has some implications in terms of potential adverse effects from drugs, which we'll go into, and just other factors related to immunosuppression. And so I really want to be sure that the patient has autoimmune hepatitis before we sort of commit to that path. But the liver biopsy can actually give us a wealth of additional information. Number one, it can tell us about the severity of the injury and the degree of liver cell damage. So we know that about 40% of patients who have extensive liver cell damage at the time of the biopsy at diagnosis will then develop cirrhosis down the line. So that can sort of give us a little bit of a window into the future. We can also stage the scarring present in the liver, which is typically scored from 0 to 4, where 0 means no scarring at all and 4 means cirrhosis of the liver. And we can also see what else might be there. So about 15 to 30% of patients who are diagnosed with autoimmune hepatitis have non-alcoholic fatty liver disease on their biopsy. And then about 5 to 10% of patients have what we call an overlap with another autoimmune liver disease. And so that might alter how patients are treated and potentially what medications they need. And so it's important to know these things. There are basically two main approaches to the liver biopsy. The first is what's called a percutaneous liver biopsy, and percutaneous just means through the skin. Those are typically done either by interventional radiologists or sometimes hepatologists like myself. And in that circumstance, we use an ultrasound to help guide where we place the needle device. We numb the skin beforehand and provide a little bit of medication through the IV. And then with a specialized device, take a very, very small snippet of liver tissue. The transjugular approach is done primarily by interventional radiology. And there they have a specialized catheter that gets fed through one of the main veins in the neck down to the liver. And again, at the tip of the catheter, there's a specialized device that takes a very, very small snippet of liver tissue. Which type of liver biopsy you end up getting will depend a little bit on where you go and also your own risk factors. So there are some circumstances that might make the transjugular approach more favorable than the percutaneous approach for certain patients. So I'm now going to spend a little bit of time talking about the initial treatment of autoimmune hepatitis. So these are the current initial treatment guidelines. These were recently updated in 2019, and the American Association for the Study of Liver Diseases, or ASLD, is sort of our main governing body when it comes to liver disease management in general. And so these are the guidelines put forth by that group. So the first component is a steroid. Typically, the options include prednisone at a dose of 20 to 40 milligrams per day. I will say that the 40 milligram dose tends to be the more commonly seen, and budestinide, which is at a dose of 9 milligrams per day. About 2 weeks after you start the steroid, your physician will usually add azathioprine at a dose of about 50 to 150 milligrams per day. There will be some differences, however, if, for instance, you are found to have cirrhosis at the time of diagnosis or if you have severe liver failure. And most folks actually who have liver failure are hospitalized, so they may actually get some of this initial management while they're in the hospital versus as an outpatient. So let's talk a little bit about steroids. So unfortunately, steroids are a blessing and a curse. They work extremely well to calm down the inflammation from autoimmune hepatitis, and they work very quickly. And there is really no other effective alternative. However, they have lots of unpleasant side effects. About 50% of patients with autoimmune hepatitis will discontinue steroids due to cosmetic changes, so for instance, acne, fluid retention, or obesity. They also cause increased blood sugars, diabetes, increased blood pressure, difficulty sleeping, irritability, upset stomach, among others. We also need to think about patients may have some pre-existing conditions that may actually be worsened by steroids. I mentioned the issue of diabetes and hypertension or high blood pressure, obesity, but also things like glaucoma, cataracts, osteoporosis, and perhaps some mental health issues as well. Those may be worsened by steroids, and so your physician should think a little bit about that in addition when starting the treatment plan for autoimmune hepatitis. So what about this distinction of budestinide versus prednisone? So budestinide is a drug. It is a steroid, and what happens is that there is increased early drug metabolism, and so theoretically, this leads to less side effects. What happens is that when you ingest budestinide, most of it is absorbed and sent right to the liver, where it has its effect for the autoimmune hepatitis, and then is quickly metabolized there. So less of it goes to the bloodstream to then cause all these other side effects from steroids. The reality, though, is that when they've done research studies comparing side effects in autoimmune hepatitis patients with budestinide versus prednisone, you actually see very similar rates of side effects in many studies. Some do show improved side effects of budestinide, but it's not consistent. And then the other thing to remember is that budestinide really cannot be used in patients who have cirrhosis or liver failure. Those patients do have to get prednisone. Ultimately, with steroids, the goal is to minimize the duration of steroid use as best as you can. And you may have the opportunity also to transition potentially from prednisone maybe earlier in your initial course to try to quiet everything down, then maybe switch to budestinide at a later time frame. And that might help us offset some of the side effects. What about steroid weaning? So the guidelines basically say that you should gradually wean your prednisone from 40 milligrams to 20 milligrams over about a 4 to 8 week period. During that time, usually we're checking labs pretty frequently because we want to make sure that we're having a nice response. So usually every 1 to 2 weeks. Then once you reach that 20 milligram mark, the guidelines recommend that you wean a little bit slower. So about by 2.5 to 5 milligrams per week, every 2 to 4 weeks, until you're about down to 5 to 10 milligrams per day. And during that time, usually we can start spacing out the labs a little bit more. Once you reach a normal ALT, so depending on the study and the guideline, that can be an ALT less than around 19 to 25 for women, or less than 30 to 33 for men, then you can consider stopping the steroid. However, it's important to remember that guidelines are really only a guide. And so there may be differences in practice among liver specialists. So for instance, I will say, I tend to wean a little bit quicker for that second bullet point up top. I will tend to continue weaning every week or two, as long as I'm getting a nice response. So there might be some differences across specialists, and there may be also some differences according to patient factors. For instance, patients may have risk factors, as we discussed previously, either liver-related or related to other illnesses that may be complicated by a long steroid course. So in those circumstances, we may actually wean a little bit quicker as long as we're getting a good response. The other thing is the treatment response, right? Some people, their autoimmune hepatitis just needs a little bit of extra time. And so we'll be monitoring that consistently throughout the initial period of treatment. And then lastly, in terms of how patients are doing with the side effects from the steroids. So some patients really feel awful. And so we need to be mindful of that. And, again, as long as we're assessing a nice response, sort of meeting patients sort of halfway between to try to balance some of these side effects while at the same time treating the autoimmune hepatitis. What about azathioprine? So one of the first things that occurs in the treatment for autoimmune hepatitis is we check this important blood test, which I'll just give you the short name because the long name is very, very long, called TPMT. And what that is a test that looks for a particular genetic mutation. It's quite rare in the population, but it can lead to a large drop in white blood cell counts when patients are treated with azathioprine. And so we want to know ahead of time whether a patient has that risk before starting azathioprine. So usually that test does take about a week or two to come back, which is why the guidelines basically say that you start azathioprine about 2 weeks after starting prednisone. So the test gets run, assuming that the person does not have this particular genetic risk factor. we start the azathioprine about 2 weeks later, and the goal is really to continue this long term unless there is side effects or a loss of response. It is really the only first-line agent, aside from steroids, of course, for autoimmune hepatitis. However, azathioprine does have some side effects, some of which more unique than other medications. And so I like to break them down into the things that patients will experience early. So usually these occur less than a month after starting. And these are typically actually not related to the dose of azathioprine. It's what we call idiosyncratic. And so these actually tend to be more common than later side effects and are one of the more frequent reasons for stopping azathioprine in patients with autoimmune hepatitis. They include nausea, vomiting in up to about 20% of patients, pancreatitis, which basically means inflammation of the pancreas, and that can be quite severe and lead to hospitalization. That occurs in less than 5% of patients. This sort of unusual syndrome of recurring fever, sometimes with a rash, that's thought to be essentially similar to an allergic reaction to the drug, that occurs in less than 5% of patients. And then there's this very rare sort of unique liver injury where patients present with jaundice. And that usually actually occurs a little bit later, sort of in the 2 to 12 month period. And that can be associated with azathioprine. The dose-related side effects usually occur about 1 to 3 months after starting, so a little bit later. And these may actually get a little bit better when you lower the dose. And they can include low blood counts, so in particular, low white blood cell counts and low platelet counts. You can also have elevated liver enzymes from azathioprine, although usually it's mild. And then lymphoma has been reported in patients who are being treated with azathioprine for other illnesses. In particular, it's been studied in inflammatory bowel disease. This has not been definitively shown in patients with autoimmune hepatitis. And in fact, I'm working on a research study with some colleagues looking into this very question. So it's a little unclear. However, it has been reported in patients who are being prescribed azathioprine for other diseases. So I'm going to spend my last segment just talking about ongoing care. So what happens next once you've started your treatment, your initial treatment, assuming that everything's going nicely, that the response has been good? Once the ALT is stable and in the normal range, your physician will continue to space out labs, typically every 3 to 6 months or so. And for patients, for instance, that I have who are on very stably controlled, they may get blood tests maybe twice a year. Typically what we're checking for are the liver tests, the IgG level, and then oftentimes we're monitoring the blood counts, especially in that first year, in particular, given the relationship with azathioprine and some of the lowering of blood counts that can occur. We may also periodically check for liver scarring using stiffness tests. So there are a couple different non-invasive tests that we can get that can give us a sense of, is there any scarring or fibrosis that's occurring over time with patients? And that includes the FibroScan or elastography, which can be done either as part of an ultrasound or an MRI. And those usually we will check every couple years or so. Liver stiffness does not typically develop overnight, so it does take some time for that to occur. So usually we'll check for that every 1 to 3 years, depending on sort of what's going on with the patient. The goal is really to achieve 2 years of normal liver tests, and that is what we would call remission. And at that point, you can consider stopping treatment. It is recommended, although it's not an absolute, that you have a liver biopsy before you stop treatment. And the reason for that is that about 1 in 5 patients who have normal liver tests, if you take a biopsy, will actually have low levels of inflammation. And so it can be really helpful to really understand, are these patients going to do well once we stop treatment? Up to 50 to 80% of patients will have a loss of response to the initial therapy, or what we call a flare or a relapse of their disease. It is more common in younger patients, so usually under the age of 40. And it can even occur in up to half of patients who have achieved that 2-year period of normal liver tests. Sometimes when patients have a flare or a loss of response to the initial therapy, we may retreat those patients with prednisone to sort of, again, quickly get things under better control, and then switch whatever backbone medication they're on, so azathioprine usually, to an alternative medication. So for instance, something called mycophenolate or even tacrolimus. And then there are a couple other things that we'll be monitoring. So blood sugars, as I mentioned, that can be an issue in patients who've received steroids for some time. And so usually we can monitor for that on your routine lab tests by looking at the glucose level, or we may order what's called a hemoglobin A1C, which can help us look for diabetes and prediabetes. Your blood pressure should be monitored, and your weight. It's also recommended that we keep an eye, probably on a yearly basis, on your cholesterol and triglyceride level, again, given the relationship with the steroids. Your bone strength should be assessed, and that's done with a special X-ray called a DEXA scan. It's usually recommended that we check a DEXA scan at the start of treatment in patients who have risk factors. So maybe those that are a little bit older, or for whatever reason have a risk factor for osteoporosis. And then usually we will continue to monitor that every 2 to 3 years after diagnosis. Vitamin D deficiency is recommended to be checked for once a year. And then I'll just mention pregnancy. So pregnancy, of course, is not always planned, but as much as you can have a conversation with your doctor beforehand, even if you're sort of contemplating or maybe not even considering strongly, it just makes your care in a way much more smooth when you do become pregnant. And at that point, you can have conversations about the medications you're on, what sorts of risks there may be or not, for instance. And so the more we as physicians can be aware of your plans, the better. What about vaccines? So it is strongly recommended that you receive the yearly influenza or flu vaccine, as well as the pneumococcal or pneumonia vaccine, and vaccination against hepatitis A and hepatitis B. Many patients may actually already be immune to hepatitis A, especially folks that are a little bit older. It was very common to be actually exposed to hepatitis A in childhood. So oftentimes as part of those initial lab tests, we're looking for whether or not you're already immune to that. Hepatitis B, it's a little dependent on what kind of job you have. If you work in healthcare, everybody tends to be vaccinated already against hepatitis B, or you may have been vaccinated in childhood as well. I would also consider the recombinant zoster vaccine. So that's the newer generation of the zoster vaccine called Shingrix. And then the vaccines that we recommend avoiding are what we call, quote, live vaccines. And so they're live vaccines because there's this small risk that by getting the vaccine, you may actually get the disease that they're meant to protect against. And so the two main live vaccines are the measles, mumps, and rubella vaccine, or MMR. Most of us have been vaccinated in childhood against MMR, but sometimes folks are recommended a booster later in as they get older. So that would be one to avoid. And then the older version of the zoster vaccine, which was called Zostavax. And then we can't not talk about COVID-19 during this session. So we do thankfully now have several vaccines available against COVID-19. These are strongly recommended. We do think that the benefits outweigh the risks. I will mention, though, that there are few studies in patients with autoimmune disease who were actually treated at the time of receiving the vaccine, so that the original clinical trials, while they included patients with autoimmune disease, if you were being treated for an autoimmune disease, you were excluded from the trials. And so we're left with at least seeing how the response has been in the general population. So far, we have not seen any major concerns. In addition, currently, there's really no preferred vaccine type or maker. So as you know, there are now 3 commercially available vaccines against COVID-19 here in the US. There has been no clear sense that one is better over the other, or one is more risky over the other. The one thing that I think is probably more important to focus on is that your level of protection may not be as high as what's reported in the clinical trials if you're on medications for autoimmune hepatitis. And so as much as you can, continue to use common sense and your usual precautions, whether that's wearing a mask, some social distancing practices, until we achieve lower circulating virus in the population. And then importantly, do not stop your medications if you are, to be vaccinated. And lastly, I'll just take a couple moments to just, reiterate that it really is it's a team approach to taking care of autoimmune hepatitis, and it involves a partnership, not only between you and your doctor, but between you and your family, community, and support people, and also between your physicians. So your primary care doctor, your endocrinologist, if perhaps you're seeing them for related conditions, your rheumatologist, if that applies to you, and even your mental health provider, if that's something that is also present. And it's important that you ask lots of questions and seek support from associations like the AIH and any other groups. It can be something that, as I said, is a disease that many patients have for many, many years. And ask your doctors questions. There is really there's no shortage of important answers that need to be addressed. And thank you so much for your time.